good afternoon, everybody. Thank you so much. I have a lot of friends and partners here in the audience, so it's really lovely to see you all. And I want to thank all those that have been involved in the Calciano Symposium for their work to supporting the families and healthy development of our youth by bringing forward long-standing commitment to serious topics and issues that impact our youth, all of our children, from being able to thrive and find success. As the mayor of the city of Santa Cruz, and as also a professional in education, I fully share your value and your commitment, and I believe that we all share responsibility and we all play a role in supporting our children finding success. And this requires collaboration and focus and ongoing education. So I want you to know that I stand here with you as a partner and as an advocate. So with that, it's my honor to introduce a wonderful provider in our community, Jen Hastings. So Jen Hastings is an MD, and she's an assistant clinical professor at UCSF, Department of Family and Community Medicine, consulting physician for the Health Improvement Partnership of Santa Cruz County, and co-medical director with Encompass of Santa Cruz County. I think she wears as many hats as I do. She has been working with the Safe RX Santa Cruz since its inception in 2015, increasing access to medication-assisted treatment and naloxone and developing pain management guidelines. As the physician at Planned Parenthood Westside for 20 years, Jen piloted integrated behavioral health, mindfulness, and approaches to care and transgender care. Jen continues to work with the transgender community, teaching nationally and internationally, and has been teaching mindfulness with local community centers and the Pajaro Valley Unified School District. As part of the California Healthcare Foundation Leadership Fellow, Jen worked with Encompass to open the mindfulness-based medication-assisted treatment program in August of 2018. We're so lucky to have her in our community, and it's been an honor to introduce her.
Thank you so much. It's a real honor to be here and to present on the behalf of SafeRx Santa Cruz County. There should be a number of people in the room who I am who have participated in SafeRx. And if you just would take a moment and stand, there should be quite a few of you. So please stand for those of you who are participating. This is an extraordinary group of people. And before I talk about them, in honor of the craziness the crazy lives we all lead at a fast pace, let's just take a moment to take a breath. Helps me too. Feel your feet on the floor, feel the chair beneath your butt, maybe the back of the chair. You've just had lunch, maybe connected with friends. And now let's return to opening our heart in honor of our community and making change in a positive direction. Thanks so much. So SafeRx Santa Cruz County brings together so many members of our community. You'll see here community prevention partners that was already mentioned by Shana this morning, our local managed Medi-Cal, Central California Alliance for Health, the County of Santa Cruz, all of the safety net clinics, law enforcement. We actually have our community hospital, the Monterey Peninsula. They started Safe Prescribe Monterey a few years, or a year or so before us, and we've worked with them in partnership. Dignity, Sutter, everyone's at the table working hard together with extraordinary engagement, collaboration, and dedication. And with that, we've seen real change. The numbers that Shana shared with you in terms of the decrease in prescriptions of opioids and the decrease in deaths, our coroner, Stephanie Fiore, really attributes that change to the work of this collaboration. So the SafeRx focus areas, thanks. So the SafeRx focus areas, which really are looking at opioid safety, but actually all prescription medications. As you learned this morning, benzodiazepines plus opioids is really a lethal combination. So one of our first focus areas is safer prescribing. So that's not just decreasing the amount of opioids that are being prescribed, but being thoughtful when looking at other issues, including mental health issues. And so we have just released our opioid guidelines, and Bill Morris will be speaking right after me to discuss with you the concept of opioid failure. And that concept really brings together what you learned about this morning from Dr. Thomas, which is looking at this issue not in terms of the good and the bad of opioids, but really balancing the benefits and the harms. So we're not saying no opioids never. And many communities have really moved to this extreme of never giving anyone a prescription of opioids because of the fear of dependency or death. There's a role for opioids, but we need to be smart about it. So in the foyer there, we have a copy of our opioid guidelines for you to review, and they are available online at the Health Improvement Partnership website. Our second focus area is increased medication-assisted treatment, and you basically had a nice long talk with Dr. Duffy looking at what that involves. And so using medication-assisted treatment in the primary care setting has been a goal for us, and we have been very successful in Santa Cruz in terms of increasing the number of providers who not just have that license, the X license, but are actually using it. Because data does show that many providers will get the license and be too scared to start providing. We're also very lucky to have federal hub and spoke funding for the increased access to medication-assisted treatment. And your third speaker in this series, Mark Stanford, will be talking in greater depth about this. So I'm going to focus the rest of the talk in part, or really using increased access to overdose reversal medication as a way to highlight the work of SafeRx. So there are many other things that we've done, but I'll try to focus on that. So naloxone, or Narcan was the trade name, is something you've heard about from pretty much all the presenters. And basically, if you encounter someone who you can't arouse, whether on the street or in your own home, there is a medication that is effective to help them start breathing again, which is extraordinary. If you give that medication to someone who is not breathing for another reason, this will not harm them. So there's no danger in trying. In addition, this is not a medication that increases behaviors that would make them want to, or make someone want to use more opioids. So there's no risk in using this medication. But what's really different about this medication is you can't give it to yourself. If you're not breathing, if you're unarousable, you're basically dependent on someone else. And I just want to highlight that that's why community is so important. And that's why the work of the Harm Reduction Coalition is critical. And I'll talk more about that. So this is the structure of SafeRx Santa Cruz County, and we have printed out way too many of these, and they're in the foyer, so take one if you think you might use it. But you'll notice that there are 4 groups. So the Prescriber Practice Initiative is the one in green there, and that's really looking at that prescriber, the guidelines. How do providers prescribe opioids? Why? The fact Dr. Thomas also mentioned that we as providers got very little training about pain. So we're trying to change that and increase the education for providers. Through the Central California Alliance for Health and Health Improvement Partnership, we've done a series of I think 6 different CMEs helping medical providers learn about pain and how to use other modalities besides opioids, right? It's much quicker to just give someone a pill than it is to try to engage in a psychosocial, supportive manner to figure out what's going on. It takes more time. And unfortunately, the structure of our medical care right now just reinforces doing something quick that may not be in the best interest of a patient. We also support what we call the MAT advisory group, which supports the providers in using buprenorphine and learning to feel comfortable with that medication. We also have our community education initiative, and I'll be talking a lot about the work of that group. And then we also work closely with the Harm Reduction Coalition. We have a metrics group as well that's trying to get data, good data, to help us understand how we're moving in terms of safety and decreasing deaths. So I'll try to go through this quickly, but basically in 2015, the California Healthcare Foundation made an offering to communities and counties in California, and we were one of 10 or 13 other coalitions that were funded. So we were very lucky to get, funded at this. It was not a lot of money, but it was enough to get us going, to bring us together. And then we've continued to get small bits of funding from the California Department of Public Health, and we worked with them to do something called academic detailing. So basically one-on-one going to providers to teach them about pain and buprenorphine and not prescribing so much, et cetera. And then through the federal government, Janice applied and we got the money for the hub and spoke that you'll learn about later. We also have a little bit of funding from something called the California Opioid Safety Network. And in 2018, we got additional funding from Sutter. So what you're seeing is sort of local funding, state funding, and federal funding. Not very much, any of it, but enough to help us get going. This is a graphic that really highlights, I think, why we were so compelled and moved in 2015. This actual graphic was put out in 2016, but there you see Santa Cruz County, bright red, surrounded by white, which means we have a much higher rate of death in our little county than any of the surrounding counties. So that's very compelling. This is also what really compelled us, the voice of youth. And I'll show and share with you this video that we created in 2017.
Prescription medications can be incredibly dangerous, and I believe that everybody should know how to use Narcan in case of emergency, and you have to save your loved one, because that's exactly what I had to do. And I believe that everyone in the community should have access to Narcan and know how to use it. Like, if somebody's overdosing and dying right in front of you, are you just gonna continue to walk by and not save somebody? I think it's important to be a community and be unified and still know that there's love and connection out here, and we need to help each other and lift each other up. I'm Caitlin Garland. I'm 23 years old. I'm from Santa Cruz, California, and I am a heroin addict in recovery. I had a really amazing childhood. I had two amazing, loving parents. I got all the love and attention that I needed. I did really good in school. I was so involved in the community. I used to feed the homeless during the holidays. When it came to drug use, it was never anything that was out of the ordinary. It was pretty rare. So one day I had to go to the dentist to get my wisdom teeth removed, and they ended up giving me Vicodin for the pain. And I had heard about prescription drugs, but I had no idea what I was in for. And I had no idea that my life was gonna start to change. I would never have thought that I was gonna become addicted to these things. So the doctor gave me about 30 pills. After I had recovered from the surgery, I had probably over 15 pills left from my prescription that the doctor had prescribed. And then eventually I got into oxycodone. I got them from friends, and those friends got them all from doctors. They did not have trouble getting them from their doctors. During that time, I started to go to a psychiatrist. That week, I was able to get a full prescription of benzos. I have never in my life struggled with anxiety. I just listed the symptoms off, and he filled the script right away. Or just wrote me a script so fast. And I continued to see him for a while, and I started to get amphetamines from him too. Eventually, oxys were too hard to find and they were way too expensive, so I had to go to a different opiate, and that was heroin. And it was a lot scarier because I did not know what I was putting in my body. I had like justified the pills because, oh, doctors prescribed them, so they must be okay. It was going from Oxy and Adderall to heroin and meth. Afterwards, my boyfriend at the time suggested that we go to the methadone clinic to get some Narcan. Thankfully, when we did get the Narcans at Emmeline, before they give them to you, they teach you how to use them. But like, I never would have thought that the person that was gonna overdose was gonna be somebody so close to me, and that ended up being my boyfriend. I never shot up again after that. It was a really traumatic experience for me. I was way too scared, and I knew that I didn't want to live like that anymore, but I didn't want to die either. So I knew I had to make a change. So I started to call different treatment centers. I did a lot of research. I went to the Beacon House in Pacific Grove. I chose the treatment center that I chose because I knew it had a medical detox. I believe that there should be more access to treatment for people that believe that they have a substance use problem. I really, really hope that the community can come together and break the stigma of addiction, because it is a disease and people think that it is a choice and that it's a moral deficiency, and it's absolutely not. And it's important for people to learn about it. I know that Narcan does save lives, and having access to it will help our community, and it will show that our community actually cares for other people and that they are willing to help save the lives of these people that are struggling.
So this was a film done by one of our interns, Keegan Farrell, with basically her buddies up at UC. So I think it's an important voice. So Caitlin talks about stigma and shame. And one of the things that I would love to hear more of from our NIH colleagues is the role of trauma. We know that adverse childhood events and the trauma surrounding that really affect behavior. And I believe that we have enough evidence to show at this point that trauma underlies addiction. Caitlin spoke about a great childhood, but even great childhoods have trauma. And so understanding both that underlying piece, plus that the antidote to stigma is empathy, is very powerful in my mind, and something that I'd love for us all to look within ourselves at what our beliefs are about addiction. I want to quote here Kelly McQuaid, who you'll be meeting just shortly, a parent, and her husband will be here with us as well. She lost her son to a heroin overdose. And when I first met Kelly, I believe it had been 3 years since her son had died, but Kelly felt so shameful about the death of her son that she was not able to really share with people what had happened. And I believe that shame and the stigma around a heroin-related dose really prevent healing of both individuals and our community. I want to talk a little bit more about empathy. What if we replace the word addict with a human being who has suffered so much that he or she finds in drugs or some other behavior a temporary escape from that suffering? What if we were forced to say that every time we wanted to use the word addict? Well, in other words, what if we actually began to care about and listen to the stories of these people? These are the words of Gabor Mate, and I'm going to mention him later in the talk, but I really encourage you to read and seek out the words of Gabor Mate. And I believe that breaking stigma is really the work that we have to do in Santa Cruz, and I think we'll see an even greater shift and improvement in all of our lives if we do this work. And so this brings me to some more of the work of the Safe RX Santa Cruz County. We're beginning to, in collaboration with the Santa Cruz City Schools, have parent education nights, and Kelly McQuaid and Rita Hewitt will be doing a class later in the spring. In addition, Shana did a really wonderful job of talking about the work of the Harm Reduction Coalition nationally. And thanks to the work of Denise Ehrlich, who's with us today, we have our own local Santa Cruz Harm Reduction Coalition doing extraordinary work. In particular, we have a homeless camp in our community, several, of course, many of you know about this issue. Denise has been going in and training folks in those camps to help save each other's lives. This is just extraordinary. Thank you, Denise, for all your work, and please, really powerful. So how many more? I only have 5 minutes. Okay, I gotta move fast now. All right. So with our prescriber initiatives, we have, as I already said, created guidelines for local providers. We're also sharing these with the hospital and really making changes in our 2 hospitals. Dr. Duffy mentioned the work in emergency rooms, and we finally have traction from both Watsonville ED and Santa Cruz Dignity ED, so we're very excited about that. In addition, there's legislation that supports us. Recently, there was legislation, AB 2760, about co-prescribing naloxone, that's the Narcan, if you have a high-dose opioid prescribed as well. So then that's law. In addition, a pharmacist can furnish or basically give to someone who presents at a pharmacy, give naloxone without a prescription. And I'll tell you a little bit more about that in a moment. Then there's incredible work, and I'm going to fly through a lot of the brochures. I want to highlight International Overdose Awareness Day. I know I only have a few minutes left, but I want to share what someone said to me. So I was teaching basically about naloxone, and a woman came up and said, I have been saved 4 times by Narcan. Do not give up on me. Do not give up on me. That to me just says it right there. People want to live, and they want to be healthy. So there's the Harm Reduction Coalition and then our Metrics Initiative. So this is Suzette from Central California Alliance for Health. We knew that patients were having trouble getting Narcan. They go to the pharmacy either having a prescription or not, and they couldn't get it. So Suzette did incredible work finding out what the hurdles were. And basically pharmacists didn't know how to bill for it. It's state Medi-Cal, not Central California Alliance for Health. Okay, so there's more to say on that, but I can't tell you. So this is our this is our website for SafeRx resources, and I'm going to just fly by. All these things are out there in the foyer. Do not let them sit in the bottom of your car. If you take one, spread it and share it. So here's Talk It Up, Lock It Up, both in English and in Spanish. This is the survey we did where we learned what Shana told you. We now have data showing that most people don't lock up their opioids, and most people, well, actually, we were impressed. 50% return their meds to the pharmacy, but almost 50% just put them in the trash, the opioids. So here are the safe disposal sites for sharps and medications in English and Spanish. Here are the community education materials that we created at SafeRx to teach, to Dr. Thomas's point, both providers and patients about pain and how to feel better without opioids. So here's the inside. Here, oops, I'll give you a little more time to look at that one. So learning about movement and mindfulness. I will not show you the TV commercial, even though it's only 30 seconds, but it does show on our local TV. This is the infographic we made to help engage all of you more in doing something about the crisis that we're still in. These are our guidelines. This is an example of the flowchart for a medical provider. If someone comes in and says, I have chronic pain, chronic non-cancer pain, here's support for a provider to sort of have opioids be the very last thing. And you'll see, and you probably can't see it, but we're looking at opioid failure, which is actually not the failure of the patient, but the failure of the opioids. That's the key. I took away Bill's punchline, sorry. And then this is about acute pain and about tapering. I think both Dr. Thomas and Dr. Duffy talked about the importance of tapering and doing that safely. This is been in our community for a while, Recovery Wave. This is where you can go to get information about where to get help. We're also going to try to improve that and to include like sort of a roadmap for Santa Cruz County and where to get help, depending on your insurance. I would just want to do a shout out to the work that's being done by our city schools, by the camp, by Encompass, by the county. This is the underlying approach for youth. It's called 7 Challenges. You can Google it. And I just want to, these are more words from Gabor Mate, but basically talk about, how am I on time? Am I done? Yeah, okay. So basically, families. It's about families and healing our families. We all have trauma. There's no shame in that. But it's not the fault of the person who's struggling. It's all of us together, working together. And that's the end. The opposite of addiction is not recovery or sobriety. It's connection.
Thank you so much, Dr. Hastings.
Thanks, Jen, for going over all the things that we've done with SafeRx, because we sort of do them, we sort of plug away at them, and to see them all together, and I know you didn't cover all of them. It's so encouraging that we've come a long ways from the last 4 years, 3 or 4 years. All right, let me see here. Get me up here. All right, so what I'm going to talk about while they're getting the slides up is what we've tried to do to take the SafeRx guidelines, looking at opioid failure, and applying it in a clinical setting. So that's what we're going to focus on today. And what we call that at Palo Alto Medical Foundation is the Opioid Assessment Service. So as discussed a number of times today, there really is a challenge for physicians, clinicians. I mean, we've gotten so little treatment so little training as physicians and clinicians in pain management, even less in addiction management. So it's sort of discouraging. But so how do we face this challenge, the polarities that we're talked about? Given that opioids may benefit some patients with chronic pain, but the risk of opioid therapy appears to over time to increase, how can we safely utilize chronic opioid therapy for patients in chronic pain for whom it's effective, but at the same time recognize when it's failed and manage that? That's the challenge that we face. And so what SafeRx did with the help of the funding from the different granting agencies is we really came up with this definition of what opioid failure is. And if you look at these 3 questions, they really balance benefit versus risk. Anything we do in medicine has benefit and risk. And what we really need to realize is when the benefits are outweighed by the risks when we use opioids in the clinical setting. So the first question, and these questions came up and were developed by a coalition of different representatives throughout the community, nurses, doctors, people involved in therapy, people involved in safety. And we came up with these 3 questions that should be asked in sequence. The first is, are serious opioid-related adverse events occurring or present? The one we talk about a lot is stop breathing. That's pretty bad. But there's other things that we have a hard time with. Opioid-induced severe narcotic bowel syndromes where you can't poop. And it's horrible. The only way you can manage that is to get off opioids. I don't care how much advertising you get from the pharmaceutical companies about these new drugs. The way you manage narcotic bowel is to get off of opioids. And the other issue that came up, mentioned by Dr. Thomas, was this phenomenon of opioid-induced hypersensitivity, whereby opioids make your pain worse. So the only way you're going to make your pain better is if you come down on the opioids. So if any one of those are present, you really got to say, well, opioids have failed. Next, are opioids being used appropriately? Now this question's a little harder because there are lots of ways that you can misuse opioids. Some aren't that dumb. I mean, some people sell their opioids to make a little extra money to buy food for the month. But it's still opioid failure, so we got to stop opioids for that patient, but we got to address their other needs. Other things might be addiction. And we see a lot of red flags, like running out early, going to different doctors, going to urgent care to get your opioids. When those things add up, or there's clear opioid use disorder or patterns of addiction, opiates have failed, we've got to stop. Now, one of the things that interestingly came up after we started doing this and applying this definition was how many patients get placed on opioids, and when we look for a reason why they need to be on opioids, we can't find it. So that's an inappropriate use of opioids. They have bad back pain, but when we do the MRI scan or we look at the old records, Really, it looks as bad as my back, and I'm up here talking and standing without being on opioids. Are opioids finally, and this is the third question, not the first, but are we meeting our goals of care on opioids? I can't, doctors will tell you all the time how many times they see patients on high doses of opioids that have high pain scores, low function, and yet they still take the treatment. What would you think of a doctor who you went to for a bladder infection and they gave you an antibiotic and then they call you up a few days later, oh, we got the results back from the culture and your bacteria in your bladder is resistant to the antibiotic I gave you, but keep taking it, I'm not going to change treatment. You wouldn't think very much of that doctor, and that's what we did all the time with opioids and pain. All right, so this is the nitty-gritty. Not a lot of numbers. N was 155, but between 2017 and 2018 in PAMF Opioid Assessment Service, we looked at patients in referral from their primary care doctor that were having problems and challenges managing their chronic opioid therapy. So what did we see? We saw that there were more women than men, which interestingly is a pattern that's seen chronic pain, chronic opioid use nationally, that there's more women than men that are on chronic opioid therapy. Why is that? I don't know if we know. Average age was 58 years, but it ranged from 22 to 90 years old on chronic opioids. The average duration of pain was 17 and a half years that they'd had pain. And almost as impressive was the average duration they took opioids daily was 10 years, which sort of corresponds with when doctors were told, when you got chronic pain, give opioids and keep giving it, and if it doesn't work, go up on the dose. Now, the average baseline pain scores when we see these patients in clinic is 5.5 out of 10, and we use a scale called the PEG scale, which does a similar thing in terms of 1 to 10. P stands for pain, 1 to 10. E stands for enjoyment of life. How much does that pain impact your enjoyment of life? So 0 would be no impact, 10, no enjoyment, and then G stands for general activity. 0, no impact on general activity, and 10 is completely in bed all the time. So the PEG score was 5.5, so not very good. The average morphine equivalent per day was 168 milligrams. That's like about 17 Norco maximum strength a day. That's a lot of opioids that these patients were on. Now, encouragingly though, about a quarter of them had already started to wean by the time they got into the opioid assessment service, so that's encouraging. Primary care doctors were recognizing things weren't working, they were talking with their patients, and doses were coming down. So where did the pain come from? When we asked these patients, they said that, and if you look on here, most of this, axial, so neck and spine, joint pain, multiple joints might be back and shoulders, and then lower extremities, so joints down here, that adds up to what, 50, 60, 70, about 80% is joint pain, musculoskeletal, and then you have a smattering of things like fibromyalgia, diffuse pains, interstitial cystitis or bladder problems, chronic abdominal pain, and headaches, but not really much. Most of these are back joint pain. Now, when we looked at medicines that they were also on, this was interesting too. Now, some things make sense. I mean, if you have chronic pain, it makes sense that you're on non-steroidals, so you're getting things like naproxen or Advil. Gabapentinoids are like a gabapentin and Lyrica, which we think help with pain, and doctors were trying to use them more to try to avoid using too much opioids. Duloxetine or Cymbalta is an antidepressant that we think has some anti-pain effects, so patients were on that frequently. Muscle relaxants, I guess you could say, make some sense, although really most experts will say that long-term use of muscle relaxants is not very helpful, maybe just short-term for maybe less than a week. But interesting to look at this, benzodiazepines. And for those of you who aren't clinicians here, benzodiazepines are like Valium, Xanax, Klonopin, things that, Ativan, things that help you with anxiety, help you forget, help you cope. Why is it that there's so many people on benzos? I think it gives us a hint as to what's going on with these patients often. Maybe it's not just physical pain managed by nonsteroidals or gabapentinoids, maybe it's the pain of life. But let's go on. Now, this got messed up, but the red shows, this basically shows how many of the patients that got referred met the criteria for opioid failure. 85%. A small percent, it was unclear, and about 12% we thought didn't meet the criteria for opioid failure, that they were doing okay on chronic opioids. They didn't meet any of those criteria, and if they wanted to, they could continue on opioids. But now this is interesting when we looked at the individual criteria for opioid failures. So let's take a look at this. Remember, 1 is, are opioid adverse events present? 2, are they being used inappropriately? 3, are we meeting goals of care or not? So it's uncommon that serious opioid-related adverse events were the only reason why opioids have failed. But when we add in other criteria, so these are just single isolated criteria being met, this is combinations of criteria, and this one here is all 3 criteria being met over 0.25% of the time, 25% of the time. The number one thing that really was by itself was they just don't work. Opioid goals of care, analgesia, and function are not being met. That's the number one reason by itself. And when you add that into the other criteria, it's pretty much present 90% of the time. So here we're starting to get the idea that maybe opioids don't work for chronic pain. Now, remember, this was a population of patients. We didn't see the ones that were doing well in chronic opioid therapy. They kept in their primary care clinics. They sent us the ones that they were having trouble with. So keep that in mind. Another interesting finding, look at the high incidence, self-reported prevalence of psychiatric illness and substance use disorder in these patients, either in their own history, their own past medical history, or family history of the same. 40, 50, 60% in all these categories. It's not uncommon for patients to say, oh yeah, I used to have a problem with alcohol, but I stopped, I'm sober, I'm so proud. And I said, that's great. Now, let's talk about your opioids. When did you start your opioids? About 10 years ago. When did you stop drinking? 10 years ago. So it was a common pattern that we saw. One substance got replaced with another. Now, to get a better sense of the problems that go on with these patients, we started asking questions about the Adverse Childhood Experiences Survey. This is, for those of you who aren't familiar, this came out of Kaiser in the late 90s, and they looked at over 15,000 patients in Southern California and asked questions about childhood toxic stress, toxic traumatic events in the ages 0 to 18. And it asked questions about emotional abuse, sexual abuse, physical abuse, neglect, whether or not there was mental illness and substance abuse in the household. So there are 10 questions, and a score of 0 means you have no stresses, 10 means that you have all the stresses that they asked about. The ACEs, there's more and more literature about this, and I would refer you to the CDC website. There's an interesting on the CDC website that explains a lot about the ACEs, but for lack of time, I'm just going to quickly go over what's thought to be what goes on with these ACEs pyramid. You have these adverse childhood experiences. It disrupts, in a physical way, your neurodevelopment. You get social, emotional, and cognitive impairment. You adopt high-risk behaviors. You develop disease, and you die early. Now, it makes sense that someone that has lots of trauma in their life, early lives, would have problems, let's say, with substance use disorder, maybe be overweight because you eat too much. But the fascinating thing is the more ACE positive scores that you get, the more likely you are to have things like high blood pressure, heart disease, cancer. So it's a fascinating, I'd encourage you to look at this because it really is, I think, a powerful way to look at not all the traumas that occur in our childhood, but many of them. Here's an example of the graded relationship between the ACE score and the lifetime incidence of illicit drug use. If you have 0, the original cohort had a 6% chance. And then with each added yes answer you gave in the ACE survey, you increased the amount of illicit drug use that occurred as an adult, up to 28% when you had 4 or more. Now look at this. So this is comparing the Kaiser cohort, which is 17,000, and just because Southern California, most people would agree, is a little atypical for the United States, I don't know. But they also included in here this behavioral risk factor surveillance survey that occurred in Washington, D.C. and 10 other states in 2010. And so this data was 53,000, and look how it's fairly close, the orange bar is that data, to how many? This is 1 ACE positive, 0 ACE positives, 1, 2, 3, 4, greater than 4. So look at this now. So the red is our cohort. When you get to 4 or greater, we double the amount of adverse childhood experiences in that population that got referred to us. Now, Filletti, who was one of the original authors of the ACE study, he mentions, I saw this statistic that came across this statistic, that males with an ACE score of greater than 5 were associated with a 4,600% increase in the likelihood of later becoming an injection drug user compared to someone that had 0 scores. So you think about the barriers that you have to overcome. You have to find a drug dealer, you have to pay out of pocket for the drugs, you have to risk health, risk being arrested. What happens if we basically become the drug dealer? So doctors, you show up at the doctor's office for back pain and you have a predisposition to have problems maybe with opioids, and your doctor gives you 30 or 50 or 60 Norco and says, here, go home and take these. What do you think is going to happen? How much greater is this risk going to be? We don't know. But this was brought out by Dr. Lemke. She's a physician up at Stanford who wrote this book, and it's an interesting read, quick read, talks about how the practices that we utilized in the 90s and 100s to give more and more people opioids led to part of our problem. Now let's look at how often people meet criteria for opioid use disorder by the DSM-4. Remember, Dr. Duffy talked about we went away from dependence and addiction. Now we're talking about mild, moderate, and severe opioid use disorder. So in our population, the biggest percent were mild opioid use disorder. So they had 2 or 3 criteria. Only about 12-15% had met no criteria or 1. And not many met severe criteria. But this is quite a bit of people that meet the diagnosis in the DSM-4 of opioid use disorder. And this is helpful because we can get these patients Suboxone when insurance companies don't want to give it to us unless they have an opioid use disorder. So this is what happens to our patients. So 3%, remember, had unclear opioid failure, 13 no opioid failure, 84% we felt had opioid failure that got referred to our clinic. Of these, we had problems with about 1 out of 5. They didn't come back, they got lost to follow-up, not to the primaries, but to us. They just didn't want to deal with the message that we had to give to them. Interestingly, about 26 or a quarter were able to wean off their opioids, which was really encouraging to me. I went into this thinking it's going to be hard to wean these patients, but they weaned on an average almost to 50% of their dose by the time I looked at this data. And then half, we transitioned to buprenorphine. And of these, 2/3 did successfully transition. They were either on a stable buprenorphine dose, or interestingly, about 26%, 27% were able to come down on the Suboxone dose, really without much urging. And then 33% maybe failed buprenorphine, or a third. So buprenorphine doesn't work for everybody, but you could say that of this group, 30% went back to their old morphine or the old opioid, but a significant percent reduced their old morphine equivalent per day or went totally off of opioids. So that's a success. If you add up this group here and these 2 groups, about a quarter of the patients that we saw, we failed to manage their opioid failure. So not bad, not bad. So in closing, let me go through sort of how we're starting to conceptualize opioid failure and chronic opioid use here at Penn. There is a group of patients in chronic pain being managed with chronic opioids for whom which opioids work, we think. What percent? We don't know. Maybe Dr. Thomas can tell us in the question and answer. But we don't know. Unfortunately, we never did the studies, and hopefully there'll be some studies coming down the line. But what do we do for these patients? They don't meet definition of opioid failure. We say we need to be safe. So get an opioid agreement, make sure they're storing safe. The opioids, make sure there's Narcan in the home, avoiding benzos and alcohol, okay? A comorbid, other meds that can cause you, increase your risk of problems. But then there's a big group of patients that chronic pain with chronic opioids for whom which we determine opioids have failed. A good percent, as we saw on the last slide, really can do okay with weaning or switching to Suboxone. So the priority here is to identify them. First, we've got to do the same safe things that we did for the first group, but then we have to also identify opioid failure, wean them, or switch to buprenorphine, which is a safer drug, we think. Might we end up with a bunch of patients on buprenorphine? We might, but it's thought to be safer, okay? Also, we need, and we were talking about this at the speaker's table, we need guidance at the primary care level how to best wean, how to do this in the best way. The biggest mistake I often see is primaries try to cut people off really quickly. and it doesn't work, we got to go slow. It might take a year, 2 years. Remember, these patients were on opioids for over 10 years. All right, then we have this third group. Patients on chronic pain, chronic opioids, who have survived significant trauma in their lives. And they're utilizing opioids, I believe, for the pain of life. These patients are strong survivors. And they are owed our respect, because if they weren't, they'd be dead from what they've been through. But how do we deal with that? Well, those patients, what we need to do, safety, wean to switch to buprenorphine if we can't, wean to be safe. And then we need to work on building resilience. And I think this is sort of what I'm encouraged to hear about the healing communities initiatives. We need to start talking about how do we build resilience in our communities? How do we deal with some of those life traumas that occurred when kids were little, way before they developed this problem of opioid failure? I think that there's 3 steps we need to do. The first step we need to do is we need to educate these patients about what they've been through. Because it's time and time again, I hear people normalizing horrible life trauma experiences. Yeah, I was hit, but I probably deserve to be thrown across the room by my loved one. Or, yes, I was abused, but isn't everybody, sort of this normalization. We need to say, no, that's not normal. This is what a normal childhood looks like. You did not have a normal one. You're a survivor. Let's talk about a better way to manage and cope with your stress of life than something that's unhealthy and illegal, perhaps. So we got to educate first about the presence of adverse childhood experiences. The second step, and I find that first step's not that hard. Patients like to hear that they're survivors and they've gone through a lot and they've come through it scathed and they've survived. And now let's work on a better way. Step 2 is coping, building resilience, and empowerment. So how do we present? We need to present to these patients a safer, legal way, if they're doing illegal things, to cope with the stress of their life that's impacted them from childhood. And there's a lot of things that are suggested in the literature. I don't know how much this has been proven. A lot of mindfulness, I think, has some pretty good data. Things like EEG neurofeedback, spirituality, nutrition, all these things, developing supportive and healthy relationships. How do you cope with the present based on the trauma of the past? And then third is, when patients are ready, we need to be ready to go deeper with our mental health colleagues. How do we process that trauma that occurred in childhood? How do we deal with and heal from it? It's often the first time that someone has told a doctor that they were sexually abused when I ask them the ACE questionnaire. They say, I've never told anyone before. And they're on failing opioids, opiates have failed them, and they need to now deal with these issues. And so behavioral treatment, EMDR, has been proven to be effective. Other things have been proven to be effective as well. But we need to build our resources in our community to deal with that. In closing, I would like to propose this, that is our national prescription opioid crisis, is it sort of a canary in the gold mine? That it's warning us that we had maybe 10, 20, 30 years ago, we've allowed this degree of toxic stress in our children, in the lives of the children of our country. And that now, as they've grown up, we're seeing the effects of that by how opioids are being both prescribed, but that was other issues, but how they've developed opioid problems. And how do we address those levels of toxic stress, both in a secondary prevention way, after they've expressed themselves as an opioid dependence and opioid use disorder, but also how do we do a primary prevention? How do we recognize these things? And maybe healing community initiative from the NIH is an important step. Other steps, how do we identify when these bad things are happening and address them to prevent this from even happening or in the future? Thank you very much.
I get to present to you probably a 6-week course in about 10 minutes, so please bear with me. Now that the introduction didn't take away from my time, did it? I want every second I can get. This is actually my second retirement from Janus. Thank you, Rudy. I had the best time of my life running their MAT, Medication Assisted Treatment Program at Janus in Santa Cruz. And I also want to give a shout out to Cabrillo College, where I teach psychology and neuroscience in the Psychology Department and Human Services with Patrick Meyer. If anyone wants to do deep dives in any of this stuff, check out the Human Services Department at Cabrillo, where they have an Alcohol and Drug Studies department. It's awesome. And that's just because I'm there. But some great associate professors. Anyway, so opioid epidemic, I'm not going to give you too much numbers, but let's put it in perspective. I love data-informed decisions. Probably about 25% of people who are prescribed opioids for chronic pain will misuse them. About 25%, there's a variety of reasons. About 10%, we see this from NIDA consistently over the past decade or so, but 10% of people using an opioid will have opioid use disorder. Probably about 5% who use prescription pain pills will transition to heroin. And of a heroin-using cohort population, probably about 80% of that group started with prescription pain meds. And it's interesting that people, most of you know this, they don't just wake up one day and decide to abuse opioids. So there's a whole sequelae and an evolution. And so we know that adolescence, particularly, is a critical period of our lives, and makes this cohort a susceptible host for a bunch of things. But 9 out of 10 people with a substance use disorder started using alcohol and marijuana in high school. A lot of interesting research, and there's no time to look at the comorbidity of early cannabis use. And we all want to embrace science, not politics, right? So we can make informed decisions. But some interesting data come out about the role of early brain exposure to cannabinoids. About half of young people who use heroin report abusing prescription painkillers before they started using heroin, and the number of high school students reported using heroin use has doubled in the last 10 years. So it starts usually, and I've seen this in 35 years of treating addiction. My average age of patients, 35, but the average length of time of meeting the diagnostic criteria for substance use disorders was about 10 to 15 years. And we know the brains are still developing in adolescence, right? And MRI scans show that maturation, development over time, means that there's meaningful connectedness. And you've all heard of the concept of pruning, right? So that's why we can't remember how it was when we were 2 or 3 years old, because things that were really important for us to remember then, we kind of take for granted. We don't need to remember that. So pruning, essentially, we're born with 200 million neurons. We prune it down about half that. And it's not about the number of brain cells, thank God. It's about the number of meaningful connections. So when reading emotions, adults rely more on the frontal cortex. Youth rely more on the amygdala. What does that mean? Well, because the frontal cortex is still developing, adults rely on part of the brain called the amygdala to make decisions. Problem is, the amygdala is more associated with emotions, impulses, aggression, and instinctive behavior. Frontal cortex is more associated with impulse control. So what does it mean? Well, it means a bunch of things in terms of how we provide treatment, how we approach adolescents, in terms of getting them to change, make healthy decisions that aren't so much reliant upon mature decision-making impulse control. It's meeting our clients where they're at. But physical, sensory connected activities that might be preferred over complex emotions, very, very adolescent, very, very emotional. And what that tells us is that persons with substance use disorders are not this homogeneous group of people who drink and use in excess. And rather, that old paradigm of addict or not an addict really is not supported by the research. Rather, we got to rethink substance abuser, addict, rehab, addictions treatment in general. In fact, what person below represents those with a greater frequency of opioid use disorder? Box left or box right? Well, box left is kind of the stereotype, right? It's about 20%. And the youngsters on the right, visiting, having fun on maybe a college campus, about 80%. It so violates our stereotypical image of who has substance use disorders. And so the neuro research I've always felt way better than when I entered the industry, we were in DSM-2. Notice the drugs with abuse potential didn't include cocaine. Can't get addicted to cocaine, really. That's why I love data-informed decisions. Yes, you can. In fact, we're teaching that to the pharmaceutical industries, that just because you're promising something is safe, effective, and non-addictive doesn't mean it's true. So But something more meaningful to us clinically is substance use disorders plotted along a continuum from mild use to moderate use to dependence and chronic relapsing severity, because that determines how we will approach each subtype. I always like George Koop's definition of the DSM-5 because it's hard to remember all this stuff. But there's 11 criteria. It's 4 C's. There's lack of control of you. When you're using, there's lack of control. There's craving, which are obsessions that drive continued use. There's the compulsion to use and continued use despite its negative consequences. So when you're doing an interview and you see those 4 C's in the history taken, probably going to have some level of substance use disorder. So we know evidence that some treatments work better than no treatment, and we know that some treatments work better than previous treatments. And these are the evidence-based treatments of the time, at the current time. Notice the list of MAT, medication-assisted treatments, are growing. The formulary probably has about probably a dozen right now, and several more in the pipeline. I'm waiting for an anti-craving medicine for methamphetamine. I noticed that Dr. Duffy was talking about different comorbidities and susceptible host factors, and she had cocaine, and I knew she was from the East Coast. Because out here, it's methamphetamine. Oh my God. So most addiction treatment programs, this is from Tom McClellan and Treatment Research Institute, most addiction treatment programs are designed for the severely chronically relapsing patient, not for the high-risk, mild to moderate larger population. This is what I'm building up to our MAT expansion project. So persons with mild to moderate opioid use disorders are generally not interested in specialty addiction treatment. Why is that, do you think? Stigma. As long as specialty care programs are the only places to deal with all forms of substance use disorders, most people with mild to moderate aren't interested. They're not going to go. So if most people with some level of substance use disorder, if you look, I'm remembering UCLA showing us the distribution and prevalence of substance use disorders, and the lion's share of people who meet the diagnostic criteria for substance use disorders are mild to moderate. The huge amount, the lesser amount are chronic relapsing severity. We absolutely need to care for this cohort. That's not a question. But the lion's share of people struggling with compulsive continued use aren't going to go to specialty care treatment because they can't identify with the cohort who's chronically severely relapsing. So where are they going? In the primary care clinics and hospitals. And recently we started to not ignore the clinical picture elephant in the lobby. Recently, not just so best practice treatments for substance use disorders, treat them in as many settings as possible, not just specialty care addiction treatment program. Here's what I'm still amazed with 35 years into the industry. Since substance use disorder begins at early adolescence or adolescence, why isn't adolescent medicine routinely screening and treating? I don't know, it just ain't rocket science. So the need for treatment, let's get into the solutions, because we have lots of solutions, as you saw from Dr. Hastings and Dr. Morris. So if we use the SAMS population-based estimates and apply it to Santa Cruz County, now I know it's a rough and dirty, because it's the only way we can, what's an approximate number of people with substance use disorders in some diagnostic criteria in Santa Cruz? About 27,000. If I use 10% of the estimates in Santa Cruz County, with a population of 274,000, is about 27,000 people who meet the diagnosis. That doesn't mean everybody's interested in treatment, just what's the numbers like? And for opioid use disorder, they say about 4.1, a little over 4% of people 12 or older misuse opioids. So if I apply that 4% loosely to Santa Cruz County, about 11,000 people meet the diagnostic criteria for opioid use disorder. So we know that since most people with opioid use disorder aren't interested or will go to specialty treatment programs for addictions treatment, they're going to be overrepresenting in ED, primary care, and urgent care centers. So why not expand the treatment net to include primary care, integrated primary care? Well, thank you, state of Vermont, with your hub and spoke model that the state of California bought into and asked for applications for programs to become a hub and spoke medication assisted treatment model program by integrating primary care into opioid use treatment. Thank you. So Janice applied and we won. We got it. Yay. So we got to expand it and try some things out here in Santa Cruz County. We call it the Central Coast Recovery Options. And the goal is to increase treatment access by casting a wide net and including primary care in the early identification and treatment of opioid use disorders by increasing the number of buprenorphine prescribers. So the hub and spoke model, the hubs are licensed methadone clinics because they know more about addictions and opioid addiction than other systems of care. And then there's the spokes who are the prescribers. So hubs, Janice treats the complex patients with lots of complex comorbidities, medical problems, liver disease, hypertension, obesity, diabetes, and serious mental illness, bipolar disorder, schizophrenia, major depressive disorder, and opioid use disorder. So they need to be seen every day. Where spokes is a less complex patient, but do early identification, screening, and induction of Suboxone. If their patients become more severe or the assessment didn't show the level of severity, they can refer to the hub for care of the complex needs. So our participating spokes in the Central Coast recovery options is the Santa Cruz Community Health Centers, Sutter Health, Encompass, County of Santa Cruz Health Services Agency, and the Cal State University Monterey Bay. In South County, because Janice has a Watsonville methadone clinic, we have Salud para la Gente, Clínica del Val, Sutter, Placita, and County of Santa Cruz Health Services Agency. We're all working together. In Monterey County, we Community Hospital of Monterey Peninsula, Natividad Medical Center, where we do addiction medicine rotation and training in addiction medicine to residents, and the County of Monterey Behavioral Health Services. So benefits of becoming a spoke, well, a lot of TA, warm line consultations with UCSF and UCLA, availability of on-site counseling services, technical assistance, and thank you, Dr. Hastings, the MAT Advisory Group. Here's some lessons we learned. Now, we're changing a practice paradigm, and most of us hate change. Now, let's just be honest. We hate change. We know we need to exercise and eat right, but geez, it's a 3-day weekend. We don't like change, but we'll change slowly and incrementally, right? So just because we had a great idea, hey, if most people aren't coming to addiction specialty treatment, but they're overutilizing primary care, let's get primary care as part of the treatment paradigm and stabilizing addiction. Great idea. How receptive is primary care to do that? No, we don't have time for that. Our panel sizes are 6 million. We're tired of screening. We don't really get practice medicine. We're assessing all that. No. But change happens slowly. So we found that there's 3 types of physicians in this model, in this new paradigm of MAT, medication-assisted treatment. Those who are actively X-licensed, they can prescribe buprenorphine, and they were prescribing. Those who were X-licensed, but they weren't prescribing for various reasons. Those who weren't X-licensed for a bunch of reasons. And so each cohort of doc had different challenges. We didn't want to assume docs wanted to screen for opioid use disorders in their patients and do medication-assisted treatment. Many don't. I finished medical school to practice medicine, not treat addiction. But some of your patients are, well, then if I identify them, I'm going to refer them to Encompass and Janice. Yeah, but they won't want to go. They can get more with you. Well, you see what I mean. Physicians don't like to screen, they tell us, for something they're unsure about, especially when the screen is positive. So if I give a CAGE aid, right, or an audit C and it's positive, and I don't know what community resources are there to refer my patient, I'm not even going to screen for that. You hate that if it's a positive screen. I don't know what to do with the results. And bidirectional referrals from hub and spokes is still a work in progress. Great concept, but we're still working on that. Let's see. Persistent myths about buprenorphine treatment serve as a barrier. There's include misconception that MAT is more dangerous than other health interventions. You can't treat drug addiction with drugs. Come on. Yes, you can. No. It's treating fire with fire. Yeah, but that's how you put out fires. It's called a backburn. Wow. MAT merely replaces one addiction with another? Really? Just taking a drug is addictions? No. MAT delivery is burdensome and time-consuming for primary care docs. Not really if you have adequate staffing and a bidirectional referral and a hub that's going to provide technical assistance. And physicians should simply stop prescribing so many opioids. I retired, say how many times have I retired now? My first retirement was from Valley Medical Center, one of the outside ambulatory care clinics at Tully. The doc who worked early morning shift had a sign on the clinic door saying, "I do not prescribe opioids." It's like, wow, that's talk about polarization. That's the extreme. So you're not practicing medicine then, essentially, right? So an MAT physician can experience stigma similar to people struggling with OUD, and few physicians willingly subject themselves to criticism by peers. Oh, is that addiction doc? And criticism about media or scrutiny by DEA. A lot of concern about that. And the other thing that physicians let us know is that they didn't want to become known as the go-to doc for their peers' addicted patients. I'll send them to Dr. Morris. He does heroin addiction. You don't have to deal with them. Just send them to Dr. Hastings. Physicians didn't want to be the go-to doc. And physicians considering prescribing bupe often unsure about the course of the illness, the clinical features of medication induction, and the maintenance and a zillions of what-ifs. They didn't understand compulsive disorders and need a lot of assistance and support available, including curbside consults. So we did discover what worked well. What did not work well is going blind to all those concerns that the physicians had. So asking physicians considering to become a spoke what they or their clinic needed most to feel comfortable was really important. So in other words, Janice didn't develop a preset things that we're going to sell the primary care clinics. Rather, we went in and say, data suggests that you might have X percent of persons with opioid use disorders. If we could help you with that, what would you find useful to you? And they said a lot of stuff, but it wasn't that we gave them a product. They helped craft the product. And I'll tell you something, each primary care clinic had a little bit different want than just a generic one-size-fits-all MAT expansion project. So PAMP looked very different than, say, Plazita or East Cliff Family Medical Clinic. Yeah. Or Salud. MAT invited physicians to the MAT advisory group that Jen Hastings started to interact with other physicians. I have my X license to prescribe buprenorphine, now what? What do I do? And talk to those who've been prescribing for a long time and get some mentoring. Training sponsorship to get their waiver. Support and technical assistance was huge. What to do if there was opioid failure, how to detect it, and how to detect if there's Suboxone failure, what are my options? On-site, this is a huge one. Probably should have led with this. Physicians don't want to do counseling. They want to do medicine. So they understand that it's a chronic disease, biopsychosocial. They can stabilize the cravings associated with dependency, but how do I deal with lifestyle? I'm not interested in doing that. We'd love an on-site counselor. Well, the Hub and Spoke grant can provide that. And peer pain coaching was an interesting thing. What worked well was how to talk to patients. So when you did a screen, how do you talk to patients? Sometimes physicians aren't trained in how to approach emotionally ridden topics. They can talk about A1Cs and they can talk about hypertension and visceral obesity and other things, but how do I talk about something as emotionally laden as substance use disorder, or opioid failure, or opioid use disorder? So practicing, helping to have that conversation based upon screening results was what they indicated was important. And then harm reduction in primary care, getting them to shift their mindset that you don't expect abstinence just because we've got you in a stabilized dose of Suboxone. There's going to be other things. If it's a biopsychosocial disease, stabilizing the disease from craving and blocking withdrawal is the first part. Then there's the really tough part of lifestyle change. And so physicians wanted to know about that and how they could be part of that. So what's next for our MAT expansion in Santa Cruz County is bringing MAT to ED and in urgent care, expanding San Benito and Monterey counties. Hollister is actually finally getting on the map. I mean, it's boomtown, right? So you have all the fun things of being a progressive startup city in a sense, but you have also the downside too of having a huge population expansion. And then we're continuing with an addiction medicine rotation and resident training program at Natividad, and we want to open up a methadone clinic, or Janice wants to open up a methadone clinic in Marina Seaside, which is pretty vacuous there. And right behind that, another vacuous part of the Central Coast is South County. There's hardly anything in Soledad and King City and Greenfield. I mean, wow, there's nothing there. Very little of it there. So don't take my word for it. Go on to the NIDA website, drugabuse.gov, and look at the preventing drug abuse. This information is free. Your tax dollar is already paid for it. Not only is it free, they send it to you for free. And you say, well, nothing's free. Yes, NIDA publications are free. So you go onto the website, go into publications, and find Preventing Drug Abuse, Community Responses, Evidence-Based Practices, Medication-Assisted Treatment, What You Need to Know, and the Principles of Drug Abuse Treatment, Drug Addiction Treatment, a research-based guide. These are really essential reads to kind of find out what's going on in the world of substance use healthcare, and what do we know about treating it, preventing it, treating it, and helping more people out. Thank you.